Hello everyone, in this video we are going to discuss about the causes of female infertility. The causes of male infertility are already described in the part 1 of the video. Here a special emphasis will be made upon the causes of female. In the female infertility, according to the FIGO manual given in 1990, the causes are tubal and peritoneal factors comprising 25 to 35%. So the fallopian tubes and the peritoneum, they are 25 to 35%. Ovulatory factor 30 to 40%. There is some defect in the fallopian tube and the peritoneum, that is 25 to 35. Some abnormality in the ovulation, that is the ovaries are involved, the ovulatory factors will be 30 to 40%, and endometriosis is just 1 to 10%. Endometriosis, it is a condition where the normal endometrium of the uterus starts growing outside the uterine cavity, that is in the peritoneum, fallopian tubes, ovaries and so on. So guys, the tubal and peritoneal factors, ovulatory factors and endometriosis. The ovarian factors are the ovulatory dysfunctions encompasses the anovulation or oligo-ovulation. Anovulation is a complete absence of ovulation and oligo-ovulation is reduced ovulation. Decreased ovarian reserve. Luteal phase defect. Luteinized unruptured follicle. Guys, each of these points will be discussed in detail in the next slides. This decreased ovarian reserve, it is a condition where the ovary will lose its normal reproductive potential. Hope the ovarian factors are clear. Oligo-ovulation or anovulation, decreased ovarian reserve where the ovary is losing its potential for the normal reproductive potential, the luteal phase defect and luteinized unruptured follicle. Physiology of menstruation. Guys, the normal physiology will be explained here so that you understand the abnormal things which are happening in the ovaries which is resulting in infertility. I have already discussed about this in the previous videos. Here we'll give a quick revision. What happens? The hypothalamus is going to secrete GnRH. This GnRH acts on the anterior pituitary. Acting on the anterior pituitary, it is going to release two hormones, follicle stimulating hormone and luteinizing hormone. First, let us see what the FSH does. This FSH, when the blood levels of FSH increases, it will act on the ovaries. Acting on the ovaries, it causes a growth of the follicles from primary into a mature Graafian follicle. See guys, ovaries, the growth of the follicle given here. These follicles are going to secrete estrogen. Once the level of estrogen in the blood increases, it causes the growth of the endometrium. On the 14th day, what happens? On the 14th day, there is ovulation. The ovary, this follicle is going to rupture and release the ovum. What happens once the ovum is released out? This residue is the corpus luteum. This corpus luteum, now the LH levels are coming into the action. The luteinizing hormone causes the production of the corpus luteum. This corpus luteum is going to secrete progesterone. Once the level of progesterone in the blood increases, they prepare the endometrium for the implantation and also for the secretory phase. Guys, what happens here? Once the progesterone level and the estrogen level, both the levels come down. Once these both levels are falling down, the shedding of the endometrium occurs from the uterus. Hope it is clear. What happens? Hypothalamus secretes GnRH, it acts on the anterior pituitary, releases FSH-LH. Role of FSH, acts on the ovaries, secretes estrogen, growth of endometrium. 14th day, ovulation occurs. Then comes the LH, luteinizing hormone. The luteinizing hormone levels, they will cause the corpus luteum formation, secretes progesterone. Progesterone causes the increase in the growth of the endometrium prepares it for the secretory phase and also for the implantation. Once both the levels fall, the ovulation is completed here. Once both the levels fall, the shedding of the endometrium occurs. This is the normal physiology. Now let us see what happens in anovulation or oligo-ovulation. The ovarian activity is totally dependent on the gonadotrophins, and the normal secretion of the gonadotrophins depends upon the pulsatile release of GnRH from hypothalamus. As such, ovarian dysfunction is likely to be linked with the disturbed hypothalamo-pituitary ovarian axis, either primary or secondary from thyroid or adrenal dysfunction. So guys, what's happening here? The ovary is totally dependent upon the gonadotrophins. What are the gonadotrophins? Luteinizing hormone and follicle stimulating hormone. These hormones are released under the action of GnRH. So, if there is some problem, if there is an ovarian dysfunction, it is probably because of some disturbance in the GnRH, that is hypothalamo-pituitary ovarian axis, HPOA, is responsible for the ovarian dysfunction. Either it could be primary or secondary, that is the other two hormones, that is thyroid and adrenal dysfunction. The normal thyroid levels and the adrenal levels are also important for the normal physiology of the ovaries. But what happens here when the thyroid levels are altered and the adrenal dysfunction, when the adrenal glands start producing more androgen, whenever there is an hyperandrogenic state, it will result in an anti-estrogenic state, that is it will suppress the estrogen level, resulting in anovulation. It does not help in the maturation of the follicles. As the maturation doesn't occur, ovulation won't take place. So guys, what you have to write here, the ovarian factor is dependent upon the HPOA. This HPOA is whenever there is some disturbance, the ovarian dysfunction is responsible. What happens here? It would be primary, that is GnRH would be directly responsible, or the other two hormones, that is thyroid and adrenal dysfunction, can occur. Thus, the disturbance may result not only in anovulation but may also produce oligomenorrhea or amenorrhea. This not only affects the ovulation but also the menses, menstrual flow is also affected. When the menses are happening more than 35 days apart, it is oligomenorrhea, and even the absence of menstruation is found. This is about anovulation or oligo-ovulation. Anovulatory cycles usually represent a lesser degree of disturbance with these normal pathways than does amenorrhea. As there is no ovulation, there is no corpus luteum formation. You can see here, when the ovulation itself is not happening, the corpus luteum is not formed. There is no rupture of the graphene follicle, the ovum is not released, so the corpus luteum formation is absent. Once there is no corpus luteum, the progesterone won't be there, and there is no secretory endometrium in the second half of the cycle. As I explained to you with the help of the flow chart on the previous slide, you saw that once the corpus luteum secretes progesterone, it will prepare the endometrium for the secretory phase. But here, the corpus luteum and ovulation, so no corpus luteum formation, no progesterone, no secretory endometrium. Luteal phase defect. In this condition, there is inadequate growth and function of the corpus luteum. Again guys, what's happening here? You see there is a rupture and corpus luteum formation. This is the corpus luteum. In luteal phase defect, the name itself, luteal phase, we saw the second half of the cycle, the luteal phase, there is some defect in the luteal phase. What's happening? There is inadequate growth and function of corpus luteum. There is inadequate progesterone secretion. Lifespan of the corpus luteum is shortened to less than 10 days. As a result, there is inadequate secretory changes in the endometrium, which is hindering the implantation. We saw guys, I have already told you in the previous slide, the same thing is repeating here. Even in the luteal phase defect, what happens? No corpus luteum, no progesterone, no proper endometrium for the implantation to occur. Luteal phase defect is due to the defective folliculogenesis, which again may be due to the varied reasons. Drug-induced ovulation. So you see, because there must be some reason for the luteal phase defect to occur. It is because of the drug-induced ovulation. The steroids are given by the physician. So the steroidal ovulation, that is drug-induced ovulation, decreased level of the FSH and LH. Whenever the FSH LH levels are reduced, so the proper stimulation of the ovaries and the secretion is not happening properly. There is elevated prolactin levels and the subclinical hypothyroidism. I told you in the previous slide that the thyroid hormones and also the prolactin hormone, they have to be in normal level for the normal physiology. But here, whenever there is hyperprolactin levels and also the thyroid levels are altered, there is hypothyroidism, which will affect the ovaries secondarily. Older women, pelvic endometriosis. You see, in the older women, there is less possibility. There is luteal phase defect in them. Less ovulation happening, the menses are going to come to cease in the later stages of life. So what happens? There will be luteal phase defect in the older women. Pelvic endometriosis. You see the condition what I told you earlier. In this condition also, dysfunctional uterine bleeding, DUB. It is because of the altered hypothalamo-pituitary ovarian axis. These are the important causes for the luteal phase defect, guys. Hope it is clear. Now we move on to the luteinized unruptured follicular syndrome, also known as the trapped ovum syndrome. Unruptured follicular, you see, it is not rupturing. The ovum is being trapped in the ovary. In this condition, the ovum is trapped inside the follicle, which get luteinized. The cause is obscure but may be associated with the pelvic endometriosis, or it is because of the hyperprolactinemia. This condition can cause the trapping of the ovum inside the follicle. We saw here that the follicle has to rupture for the ovum to come out. Sorry, here you see here the rupture happening and the ovum is coming out and the corpus luteum formation is happening. Luteinized unruptured, in the sense the ovum is being trapped inside the follicle itself. It is associated along with this capturing, that is trapping of the trapping of the ovum inside the follicle. The other two conditions, that is pelvic endometriosis and hyperprolactinemia, is also associated. Now you see the tubal and peritoneal factors, they are about 30 to 40%. Cases of the female infertility is because of these tubal and peritoneal factors. The obstruction of the tube is maybe due to the pelvic infections causing peritubal adhesions. Guys, you see here the pelvic infections. These are causing the peritubal adhesions. In pelvic inflammatory diseases, like they are undergoing some operation for the fibroids, the fallopian tube blockage and so on, what happens? There is some scar tissue left. There is peritubal adhesions. Endosalpingeal damage, previous tubal surgery or sterilization, salpingitis isthmic nodosa, tubal endometriosis and others. Polyps or mucus debris within the tubal lumen or the tubal spasm. Guys, you see here in these conditions, whenever there is some peritubal adhesions left over, the scar tissues are there, or there is some tubal surgery, or they have undergone the sterilization, the salpingitis isthmic nodosa and the uterine polyps, mucus debris, which is found within the tubal lumen and also the tubal spasm. You see here they have given the endosalpingeal damage and the small nodule or a pouching out in the isthmic portion of the fallopian tube is the salpingitis isthmic nodosa. Guys, you see there is a small nodule. It is like the nodule is pouching out in the isthmic portion of the fallopian tube. So the isthmic portion is involved and the fallopian tube, there is a nodule formed. So it is salpingitis isthmic nodosa. Tubal endometriosis, we already know the normal endometrium when it starts growing in the fallopian tube. The polyps, you can see in the picture here, and the polyp is an extra growth, mucus debris, which is found within the lumen of the tubes and also the tubal spasms. These are the causes for the obstruction. These are the obstructions of the tubes which is resulting in infertility. Let's summarize. What are they? The pelvic infection, which is causing the peritubal adhesion, and the endosalpingeal damage. Previous tubal surgery, they have undergone some tubal surgery. Salpingitis systemic nodosa, we saw it is just a small nodule like thing which is found in the isthmic portion of the fallopian tube. Then tubal endometriosis, polyps and mucus debris. These are the tubal factors. Peritoneal factors, in addition to the peritubal adhesions, even the minimal endometriosis may produce infertility. Guys, you see here the endometriosis is very dangerous. Even the minimal endometriosis can produce infertility. That is, when the endometrium starts growing in the fallopian tube, the ectopic pregnancies can occur and it can completely stop the fertility. Deep dyspareunia too often troubles the patient. You see, dyspareunia is the painful sexual intercourse. The patient will also complain of a deep pain which is found during the sexual intercourse. This often troubles the patient. Uterine factors, the endometrium must be sufficiently receptive enough for the effective nidation and the growth of the fertilized ovum. You see, the endometrium should be properly well developed. It should have a good growth and it should be receptible. It should be able to receive the ovum, and for it to get implanted here, it should be sufficiently receptive for the effective nidation and also for the growth of the ovum. The possible factors that will hinder the nidation are uterine hypoplasia. Whenever there is hypoplasia, that is decrease in the number of cells of the uterus. Inadequate secretory endometrium. If the progesterone is not adequate, there is some luteal phase defect which is not preparing the endometrium for the secretory phase. If there is some fibroid which is found in the uterus, endometritis, tubercular in particular. The uterine syncytial or congenital malformation of uterus. Guys, uterine syncytial, it is the also known as the pelvic adhesions. What happens if a woman has undergone some abortion or something? They do the DNC, dilatation and curettage. There is scraping and scrooping of the uterus. During that phase, they can damage the endometrium, resulting in the scar tissue formation, that is uterine adhesions or uterine syncytial. Congenital malformations of uterus. You can see the biseptate uterus here. These are the, like, from birth there is a malformation of the uterus. These are the uterine factors. One, the endometrium should be receptive enough for the proper nidation of the fertilized ovum. What can hinder this nidation? It could be the uterine hypoplasia, inadequate secretory endometrium, fibroid uterus, endometritis, uterine syncytial, and also the congenital malformation of the uterus. Now let us look into the cervical factors. Anatomic defects which are preventing the sperm ascent may be due to congenital elongation of the cervix. So there are some conditions which are happening in the cervix which are preventing the sperm to ascend upwards to reach the fallopian tubes, that is the isthmic nodosa where the fertilization takes place. This transport is being obstructed. It is because the congenital elongation of the cervix, second degree uterine prolapse, and the acute retroverted uterus. You can look into the picture here, the elongation of the cervix in case of the prolapse. So whenever there is an by birth congenital elongation of the cervix, the second degree uterine prolapse, and the acute retroverted uterus, these conditions will prevent the external os to bath in the seminal pool. Since the cervix is elongated, the external os cannot bath in the seminal pool since it will be only 2 ml. So since there is elongation here, the external os is not completely bathed in the seminal pool. Pinhole os may at times be implicated, or the cervical canal may be occluded by a polyp. Along with this, there could be a polyp which is found in the cervical canal. And also the pinhole external os may also be found. These are the anatomical causes. One, the congenital elongation of the cervix, the second degree uterine prolapse, the retroverted uterus. These conditions also prevent the external os. These all three conditions will prevent the external os to bathe in the seminal pool, and along with this there is pinhole os, and also the cervical canal can also have a polyp. Physiologic, the fault lies in the composition of the cervical mucus. So the cervical mucus, the pH of the cervical mucus is also very particular for the fertilization to happen, for the sperm to ascend. The pH is supposed to be 7.2 to 7.8. The fault, whenever there is a fault in the composition of the cervical mucus, so much that the spermatozoa fail to penetrate the mucus. The mucus might be scanty following the amputation, conization, or the deep cauterization of the cervix. There is some process which is happening here. These are the surgical processes which are done during the cancer of the cervix and so on. Whenever the amputation, that is, you cut a part of the cervix in a cone shape, that is conization, and the deep cauterization of the cervix is happening. During these conditions, the mucus will be scanty. The abnormal constituents will include the excessive viscid or the purulent discharge, as in the chronic cervicitis. So when the woman is suffering from cervicitis, which is the pelvic infection, and it is chronic in nature, the mucus which is secreted will be either excessive in amount, or it will contain pus, or it will be viscous. Presence of the anti-sperm or sperm immobilizing antibodies may be implicated as an immunological factor of infertility. Along with the scanty mucus found in the chronic cervicitis, you also see as an immunological factor, some antibodies will be produced against the sperm. The anti-sperm or sperm immobilizing antibodies will also be produced, resulting as an immunologic factor for infertility. So the fault lying in the cervix, what could be there? One, the composition, there must be some problem, or either the composition will be some defect, will have some defect, or the mucus will be scanty. The mucus will be scanty in which conditions? When there is some amputation, conization, or cauterization of the cervix. Then you see there could be an anti-sperm against the against the sperms. There's some antibodies which are produced in the cervical mucus, and along with that, in the chronic cervicitis, the mucus will be either excessive in amount, it will be viscous or purulent. This is about the physiological causes, that is the cervix. In the cervix, these are the causes. Now we move on to the vaginal factors which are making the woman infertile. The atresia of vagina, partial or complete atresia. Transverse vaginal septum. You see atresia, that is damage. The damage which is happening to the vagina. It could be a complete or it could be partial. The transverse vaginal septum. You can see a transversely there is a septum formed here in the vagina. The transverse vaginal septum. Septate vagina, or narrow introitus causing dyspareunia. So all these conditions, if there is a transverse septum, or there is a septate vagina, the vagina is having a septum which is dividing the vagina into two parts, there is septate vagina. Narrow introitus, the introitus is become very narrow, it is causing dyspareunia. Dyspareunia is a difficult sexual intercourse. They are included in the congenital groups. These three things, that is the atresia of vagina, transverse vaginal septum, and the septate vagina, along with the septate vagina or the narrow introitus, these things are causing dyspareunia. All these three are included under the congenital causes. These could be by birth. Vaginitis or purulent discharge may at times be implicated, but the pregnancy too often occurs in the presence of vaginitis. So guys, the women who are suffering from vaginitis, who is having a purulent discharge, we can say that the fertility is still possible in them. They can still become pregnant in the presence of vaginitis. It could be specific or non-specific. However, the dyspareunia may be the real problem in such cases. So you see the vaginitis, inflammation of vagina, she's having pain, inflammation, purulent discharge coming out. So it's obvious there will be dyspareunia. This is a real problem in such cases. Hope the vaginal factors are clear. Congenitally, it could be either atresia, transverse vaginal septum, septate, or the narrow introitus. Second thing, you can see there is a vaginitis, the pelvic inflammatory disease, vaginitis. It is causing a purulent discharge, but pregnancy is possible, but there will be dyspareunia. Showing the common causes of female infertility in a diagrammatic view, you can let us start with the pelvic causes. Endometriosis, adhesions which are found in the pelvic, that is endometriotic adhesions can also be there. Altered tubal motility, dysovulatory. Now you come to the tubal factors. It is following the tubal infection or pelvic endometriosis, the endometrium getting deposited in the fallopian tube. Ovulatory, we saw anovulation, corpus luteum insufficiency. Cervical factors, we saw ineffective sperm penetration because of the chronic cervicitis. Immunologic factor, that is presence of an anti-sperm antibody. The uterine factors, guys, we saw there is an unfavorable endometrium which is preventing the nidation of the fertilized ovum. The chronic endometritis, tuberculosis, TB of the genital tract, fibroid, synechiae, uterine synechiae, the adhesions which are formed after the surgery, congenital malformations of the uterus. These are the, like, in total, the causes of female infertility. Let us see some combined factors of female infertility. They will include the presence of factors both in the male and the female partners, which is resulting in the infertility. Guys, here both the male and the female. With that last thing, we come to an end of female. Here we are seeing the combined factor, both male and the female, resulting in these both are having some problem which is resulting in infertility. The general factors are advanced age of the wife beyond the 35 years is related. You see, after 35 years of age, the fertility of the woman keeps on decreasing. She is nearing to menopause. So, beyond 35, the fertility level decreases. But whereas in the males, the spermatogenesis will continue throughout his life. Although the fertility also will be reduced in a slight level compared to the females in the males also. Infrequent intercourse, the lack of knowledge of the coital technique, timing of the coitus to utilize the fertile period are very much common even amongst the literate couple. You see, the literate couples only who are those in the medical field will know all about the rhythm method, calendar method and so on. But whereas the other people, even though they are literate, they will not have a good knowledge about the procedures and everything. So, even in the literate couples, the utilization of the fertile period, the knowledge of the coital technique and the infrequent sexual intercourse will also be a factor resulting in infertility. With this, we come to an end of the causes of female infertility along with the combined factors. In the next video, we'll be discussing about the diagnosis which is made in the females and also how to diagnose the male infertile men. Okay, thank you. If you have understood everything and if you like my video, hit the like button and subscribe.